Hello everyone, I am Dr. Rohan Khandelwal, your Marrow surgery faculty, and in this video I'll be talking about the UPSC surgery questions which were asked in the UPSC CMS exam which is conducted recently. Now the UPSC exam is usually an exam which has multiple correct answer questions, most of them. Some of them are single correct answer questions, and most are designed from Bailey, which is what I like about them, that they're straightforward lines from Bailey which they take. So a typical UPSC CMS paper, barring the fact that the questions from GIT were a bit less, other than that it was a typical UPSC CMS paper. Now why everyone is paying a lot of attention to it is because they probably are thinking that some of these topics might be asked in the NEET exam. So I would also recommend the same to you, that quickly go through this video where I've discussed the questions, the answers, and I've discussed some important points around those topics as well. So without wasting any further time, let's get on with the questions. So the first question was, which of the following are risk factors for wound infection, right? Now wound infection, we know that malnutrition is a risk factor. We know poor perfusion is a risk factor. We know foreign particles, if they're left behind, they can also increase the risk of wound infection, right? So the correct answer is going to be 1, 2 and 4. Antibodies will not be a risk factor for wound infection. It will be the contrary, it will prevent a wound infection. Which of the following cancers are associated with exposure to ionizing radiation? So leukemia, lung cancer and breast cancer. So the answer is going to be 1, 2, 3, leukemia, lung cancer and breast cancer. Then there was a question regarding Leaf-Romany syndrome. We know Leaf-Romany syndrome is P53 mutation, and this was a very simple question. If you knew the inheritance pattern, you could answer this very quickly. And there were two options, one was autosomal dominant and one was autosomal recessive. We know this Leaf-Romany syndrome is transferred as autosomal dominant, right? So one is correct. We know it is linked with multiple cancers all across the body, including sarcomas and leukemias, and there is increased risk of brain tumors and osteosarcomas as well. In fact, I've had 2 patients in the last 1 year with P53 mutations with breast cancer, and these patients react very badly to radiation. They have a lot of side effects, and no matter how well you treat them, they will sooner or later develop some other cancer in other parts of the body, and the overall prognosis is very bad. So 1, 3, 4 will be the correct answer for this question. Okay, this was a straightforward question. This was asked in the NEET exam also. A similar question was asked last year or last to last year. A 48-year-old smoker comes to the OPD with complaints of cramping pain in both calves after walking 100 to 150 meters. Pain is relieved on taking rest and for about 2 to 3 minutes, and the patient is able to walk some more, after which the pain recurs. This is a sign of which condition? So we know this is a classical description of intermittent claudication or vascular claudication. Now if you remember my lectures, I have told you that whenever you get this patient, you always need to differentiate this patient from 2 other conditions, osteoarthritis and neurogenic claudication, right? So if we see here, if we see this intermittent claudication, there will be cramping pain after walking a certain distance. Pain is usually in one muscle group lower than the block, and with time, as the block increases, the pain is also going to increase. Osteoarthritis, on the other hand, the classical history would be maximum pain on the first step. So when the patient gets up in the morning, first step when they take that is excruciatingly painful, but as the day progresses they get better and pain is in the affected joint. Neurogenic claudication is lumbar canal stenosis, right? And this is going to vary with posture. That is the most important thing. Pain varies with posture and is relieved when the patient bends forward. So these are the points which you need to know, and this is what can help you in differentiating these conditions. The answer to the question in UPSC was straightforward. It was a case of intermittent claudication. Now the next question, there was a midline neck swelling just below the hyoid bone, and it is managed by cyst trunks operation, and this leads to the need for post-operative thyroxine replacement, right? So one part was very easy. we know what is the diagnosis. The diagnosis is that we are dealing with a thyroglossal cyst. But what is the catch here? The catch is that normally if you remove a thyroglossal cyst, you might not require thyroxine replacement. Why is the patient requiring thyroxine replacement? Because this thyroglossal cyst might be the only functioning thyroid tissue. And this is beautifully written in a line in Bailey where they've said that whenever you have ectopic thyroid tissue, always do a thyroid scan. Why do I need to do a thyroid scan? I need to do a thyroid scan to be very sure that we are not missing out and we get to know that this is the only thyroid tissue or not in the body. Now we know thyroglossal cyst presents as a midline swelling in the neck, and it is the persistence of the thyroglossal tract which is there. The most common look. So we know that thyroglossal cyst is nothing but a persistent thyroglossal tract, and the most common location for this is subhyoid. That means below the hyoid bone. And the features are that of a midline neck swelling which moves with deglutition and with protrusion of tongue. The management is cyst trunk surgery, which was mentioned in the question. Cyst trunk surgery is removal of the cyst, part of the hyoid bone, because the tract goes through the hyoid bone and the tract till the base of the tongue. Now, we should always do a scan to rule out if this is the only functioning thyroid tissue, right? Because if it is the only functioning thyroid tissue, you need to replace thyroxine in this patient. And we also know that long-standing cases of thyroglossal cysts, so long-standing cases of thyroglossal cysts can develop papillary thyroid cancer. Now the next question was a 40-year-old smoker who came with soreness of the tongue since the last 2 months. On examination, there was poor oral hygiene and there is a white plaque over the lateral border of the tongue. What is the next step in the management? Now we know this white patch is classical of leukoplakia, right? And we always differentiate it from candidiasis. Leukoplakia is a white patch which cannot be rubbed, right? We know this is a white patch which cannot be rubbed off, whereas candidiasis, we know you can rub it off. And leukoplakia will be seen in smokers, tobacco chewers, and this can increase the risk of cancer. So in such a case, when they had given this kind of a history and these options, the best answer is that you do a biopsy of the lesion to rule out a cancer, right? Of course, they did not mention that, stop smoking, observe, take antioxidants. All those were not mentioned. They had given vitamin C, but not mentioned that stop smoking and observe carefully. So that is why we will do edge biopsy to confirm the diagnosis. And leukoplakia versus erythroplakia. Erythroplakia we know is a red patch, and erythroplakia has a higher risk of cancer as compared to leukoplakia. Okay, 6 to 9 times higher risk of cancer as compared to leukoplakia. And whenever you get such lesions, to confirm whether there's cancer or not, we need to do an edge biopsy. Why not from the center? Because the center is usually necrotic in these patients. Okay, next question. A 60-year-old lady comes with a recent onset increase in a long-standing swelling in the front of the neck. The swelling, which was small and was present since last 30 years, but has now increased to twice the size in the last 2 months. It is hard and it moves with deglutition. So we know that we are dealing with a thyroid swelling. Okay, this much we know, we are dealing with a thyroid swelling, right? Why are we dealing with a thyroid swelling? Because it is moving with deglutition. It is in the front of the neck. And which thyroid swelling you have since 30 years? It will probably be a multinodular goiter. MNG is multinodular goiter. Now, multinodular goiter, rapid increase in size. The patient is 60. In 2 months, it has doubled. What are the differentials which are going to come to your mind? Follicular thyroid cancer or anaplastic cancer, right? And between follicular and anaplastic, we know follicular is more common. Any which ways, they are not asking what is the histology, whether it is follicular or anaplastic. Could be either, but we know follicular is more common because of a long-standing multinodular goiter. Okay, so here it has undergone malignant transformation, whether FTC or anaplastic, we don't know, but this is what we had to mark in this answer. Right, so that was the next question which was asked. Let's move on to the other set of questions. Surgery questions were quite a lot this time. Next one was Barrett's esophagus, which we know is a straightforward question. It has been asked many times in the exam. We know Barrett's is intestinal metaplasia, right? So we know Barrett's is specialized intestinal metaplasia, right? So this is true of squamous to columnar epithelium. It increases the risk of adenocarcinoma. This also we know is correct. Ingestion of NSAIDs is a risk factor. No, we know that GERD is a risk factor. NSAIDs can give rise to peptic ulcers, but GERD increases the risk of Barrett's esophagus. And EMR, endoscopic mucosal resection, is a treatment option that is correct. So 1, 2 and 4 are the correct answers. Now we know in Barrett's you get red velvety mucosa, and this is specialized intestinal metaplasia which is there. 3 types of Barrett's: long segment is more than 3, short segment is less than 3, and cardia metaplasia is microscopic Barrett's. Now these patients might be asymptomatic or they might exhibit features of GERD, and the only way to confirm the diagnosis is to take an endoscopic biopsy, and we take multiple biopsies in Barrett's to confirm the diagnosis. The pathognomic finding for Barrett's esophagus, this has also been asked in the exam. The pathognomic finding, the presence of these cells, these are known as goblet cells, right? These are known as goblet cells, and this is the pathognomic finding which is there in Barrett's esophagus. We can even do chromoendoscopy to confirm the diagnosis, and we can use methylene blue in patients to confirm whether there is Barrett's or not. Now, Barrett's esophagus, there is another classification which is known as the C and M, the Prague C and M classification. This has been updated in Bailey, where we measure all the distances from the GE junction. So the maximum area, the maximum point where there is circumferential Barrett's involvement is labeled as C, and the point from the GE junction, which the highest point from the GE junction which is showing any signs of Barrett's, is M. So higher the C and higher the M score, more is the risk of malignant conversion, right? This is the Seattle protocol which is used for management of Barrett's esophagus, and these are the updates which you need to know from the latest Bailey regarding Barrett's esophagus. So Seattle biopsy protocol is a 4-quadrant biopsy protocol every 2 centimeters, and we also take biopsies from suspicious areas. We know that radiofrequency ablation is the most popular and cost-effective method, but EMR, endoscopic mucosal resection, this is what was asked in the question, can also be used. But the problem is when we are doing a 360-degree EMR, there is a higher rate of stricture which is there in these patients. So this is what we need to remember, and this is what was asked in the exam as well. Which of the following are complications of liver trauma? Now we know whenever there's liver trauma and there's liver injury, there can be a risk of a liver abscess. There can be bile duct injury and a biliary fistula can form. Portal thrombosis we know can happen post injury, but liver failure is uncommon because you would have to have 85 to 90% of the liver damaged, and then only it will lead to liver failure. So we've rarely, I've hardly seen any case where after abdominal trauma the patient has developed liver failure due to liver trauma. So 1, 2, 3 are the correct answer here. Which of the following are local complications of acute pancreatitis? So now we know acute pancreatitis, you can have local complications and there can be systemic complications as well. We know pseudocyst is a local complication. This is correct. Pleural effusion will not be a local complication. Paralytic ileus is a local complication, which is why you get the sentinel loop sign, the colon cutoff sign. All these signs can be seen in acute pancreatitis, and they are a sign of ileus. Why ileus? Because of inflammation, the bowel is going to get stunned and it will not contract. Acute fluid collection, which is also mentioned in the Atlanta guidelines, which is less than 4 weeks, the wall is not fully defined, that can also be a local complication of pancreatitis. You need to drain it outside. But pleural effusion, and that to which side? It is usually left-sided pleural effusion. This is not considered as a local complication. So 1, 3, 4 will be the correct answer here. Which of the following are risk factors for the development of pancreatic cancer? Now we know pancreatic cancer is linked with smoking, it's linked with diabetes, it's linked with male gender. So Caucasian identity is not a very important factor for pancreatic cancer, but cigarette smoking, diabetes and male gender is a risk factor. The next question which we need to know, moving on. So the next few questions were regarding hernias, and the first question was regarding umbilical hernia. Now we know umbilical hernia is a hernia which is coming out through the umbilicus. It is going to cause eversion. The options were patients are commonly overweight with a thinned and attenuated midline raphe. This is correct. Mostly patients complain of pain due to tissue tension. Right. Men are more commonly affected than women, and hernia repair can be done via the Mayo technique. So here the options are 1, 2 and 4. 3 is not correct. Females are more commonly affected than males when we talk about adults, right? In children, in newborn, males are more commonly affected, but in adults, females are more commonly affected than men. So the correct answer is going to be 1, 2 and 4. And if we look at these hernias, we know this is an umbilical hernia. Right, this is an umbilical hernia where you can see eversion of the umbilicus. This is another umbilical hernia where you can see there is umbilicus is completely everted. In fact, there was an FMG question which was asked recently in their exam where they had shown such a hernia and they had asked about the management. And in such a case, you know, when the defect is big, you are mainly using a mesh. But in such cases, you also have to excise the redundant skin. So always remember, if you have such redundant skin, remove the redundant skin and you have to put a mesh as well. This is a para-umbilical hernia which is there. This also you can see the para-umbilical hernia where you get this smiling umbilicus where umbilicus is just forming one boundary. Where umbilicus is just forming one boundary of the defect, and this is usually a narrow defect as compared to the umbilical hernia, and that is why para-umbilical hernias have a higher rate of strangulation and obstruction as compared to umbilical hernias. Okay. So that was the question which was there. There was a question regarding mesenteric cysts as well. So there was a question regarding mesenteric cysts as well, and there was a time when all exams 1 year asked questions from mesenteric cysts. Again, UPSC has started the trend maybe, and you might have questions from mesenteric cysts in most of the exams this year. Let's see that. So which of the following statements is true about mesenteric cysts? It occurs most commonly in children less than 18 years. This is false. It is seen in 3rd to 4th decade of life. More common in males as compared to females. False. More common in females as compared to males. Most commonly presents as painless abdominal swelling. This is correct. Percutaneous aspiration is done. This is wrong. Now, mesenteric cyst typically presents as Tilloch's triad. Tilloch's triad has been asked in the exam. It presents as a peri-umbilical lump which moves at right angles to the attachment of the mesentery. Now, what is the attachment of the mesentery? The mesentery is attached from the DJ flexure to the right sacroiliac joint. So, it moves at right angles to it, not along that line. And this sign is known as the Tillock's sign, which was asked in the INI-CET exam. So out of the triad, this is the Tillock's sign which is there, and there will be a transverse band of resonance also which is there. Now, mesenteric cysts are of two types. You can either have chylolymphatic cysts or enterogenous cysts. Chylolymphatic cysts are the most common, and this is nothing but sequestered lymphatic tissue, and chylolymphatic cysts have independent blood supply. They have independent blood supply, and that is why enucleation can be done in a chylolymphatic cyst, because I am not disturbing the blood supply of the bowel. Enterogenous is sequestered bowel tissue. It is thick walled, and because it shares its blood supply with the bowel, we have to carry out resection and anastomosis when it is an enterogenous cyst. Okay. So these were the points regarding mesenteric cysts which you should know for the exam. Another simple question, which is the most common cause of perforation in esophagus? We know it is iatrogenic, usually due to endoscopy, and it is in the upper one third. Why the upper one third? We know that the narrowest portion of the esophagus is the pharyngoesophageal junction at the level of C6, and that is the most common site where a perforation can happen during endoscopy, and patients would usually present as pain following that. Which of the following are stages of damage control surgery? Now, there were two questions from damage control surgery. Damage control surgery, we know the stages are patient selection, right? These are the stages. You have patient selection, then you have to do the emergency surgery where we have to control the hemorrhage and prevent contamination, right? Then we do temporary closure of the abdomen and shift the patient to the ICU for correction of physiology, for the correction of the triad. What is the triad? The lethal triad is coagulopathy, hypothermia, and acidosis, right? So ICU care, then definitive surgery has to be done, and then closure has to be done, right? So if you look at the options in the exam, patient selection we know is a criteria. Control of hemorrhage is there. Resuscitation in ICU is there. There is no preventive surgery, right? No preventive surgery in damage control surgery. So 1, 2, 3 is the correct answer here. The next question was regarding renal cell cancers. Renal cell cancers, they mostly arise from the epithelium of proximal convoluted tubule. Now we know that the most common RCC is the clear cell type, and clear cell does arise from PCT, so this is correct. Female preponderance, wrong. It has male preponderance. Major subtypes are clear cell, papillary, and chromophobe. This is correct. And surgery is the mainstay of RCC. We know it is a chemo and radio resistant tumor, whereas Wilms tumor, which occurs in the pediatric population, is chemo and radio sensitive. Both RCC is radio and chemo resistant. So 1, 3, 4 will be the correct answer here. And this table basically summarizes all the points regarding renal cell cancers. We know that the most common renal cell cancer is clear cell. Prognosis wise, the best prognosis is of chromophobe type, and the worst prognosis is of the collecting duct type, right? So this has the worst prognosis, the collecting duct type. Now we know clear cell arises from proximal convoluted tubules, and key feature are the clear cells, which are basically glycogen rich cells which become clear when you do fixation. Papillary RCC arises from PCT or DCT, and you get psammoma bodies there. Chromophobe RCC has the best prognosis, and you get plant-like cells and raisin-like nucleus. Worst prognosis is with collecting duct. One more question which has been asked, that in patients with sickle cell anemia, you get medullary subtype. That has also been asked in the exam. Now there was a question regarding polycystic kidney disease. So the question was that cysts may occur in liver, pancreas, and arachnoid. This is correct. You can get arachnoid cysts as well. Most commonly manifest between 20 to 30 years of age. No, it occurs between 3rd to 4th decade of life, and we know that the most common presenting feature is hypertension between the 30s to 40s, not between 20s to 30s. Clinical manifestations are renal and extrarenal. Extrarenal will be liver cysts, pancreatic cysts can be there. You can have mitral valve prolapse. There can be berry aneurysms in the circle of Willis as well. Men tend to progress to renal failure more rapidly. This is also the correct answer. So 1, 3, 4 are the correct statements here. 22 was a very straightforward question. ESWL is used for the treatment of, we know ESWL is used for the treatment of renal stones, urinary tract stones, and basically ultrasonic waves which we give to a stone, they will shatter the stone into smaller pieces, and those pieces will travel down the ureter and come out. That is ESWL. ESWL, there can be pain, hematuria, infections, or Sten stress. These are the complications which can be there of ESWL. Sten stress is stone street, means multiple fragments are going to block the ureter and form a street there. That is known as stone street or Sten stress, and that can be one of the complications of ESWL. Consider the following features. Which of the following are signs of brain tumors, right? So raised ICP, seizures, headache, fine, focal deficit. All four are signs of CNS tumors. Patient can come with any of these four signs and you should be aware of that. Okay. The next question was another question based on hernia. This was regarding diaphragmatic hernia. So this question was, which of the following are correct for herniation from the foramen of Morgagni? Now we know foramen of Morgagni and Bochdelic. These are congenital diaphragmatic hernias which are there, right? And Morgagni we know is right anteromedial, right? So let's look here. Morgagni is right anteromedial, whereas Bochdelic is left posterolateral. And Bochdelic hernia, I've told you this is the most common and left posterolateral, and this is due to defective development of the pleuroperitoneal canal, and stomach spleen can herniate here. Morgagni on the other hand occurs anteriorly. There is defective central tendon of diaphragm, and the most common structure which herniates is the transverse colon. So you can see here in congenital diaphragmatic hernia, the bowel is sitting inside the thorax, and if bowel sits inside the thorax, the lung is not going to develop, and that is why pulmonary hypoplasia is the most common cause of death in congenital diaphragmatic hernias. And we know that we need to diagnose and then operate these patients. There is also in utero treatment available now, which is fetal tracheal occlusion, and that is known as FETO. That is also used for treatment of congenital diaphragmatic hernias. So Morgagni does not occur posteriorly. Transverse colon is the most common content. Defect is between sternal and costal attachments, and it is a congenital hernia. We know this. So 2, 3, 4 will be the correct answers here. Okay. Moving on to the next set of questions which are there. So this was a simple question. If you've been to the surgery OPD, I'm sure you would have seen this. A 20-year-old girl comes to the OPD with a progressively increasing swelling over the dorsum of the left wrist. The swelling is cystic, non-tender, and becomes more prominent on plantar flexion. Swelling is 2 into 1 centimeters. This is a classical ganglion cyst based on the description location. It is on the dorsum of the hand, usually linked with the tendon. And these ganglion cysts we aspirate, and we can inject hyaluronic acid into these lesions to prevent a recurrence. Sebaceous cyst, you know, is a blocked hair follicle duct, and sebaceous cyst you can't pinch the skin. That is there, and punctum is there. So punctum will be the classical sign for sebaceous cyst. Dermoid cysts, will be found at the sites of embryonic fusion. So you will either have post-auricular dermoid or it will be there in the outer canthus of the eye. That is what you should remember. Now, 56-year-old female is diagnosed with gallstones and is undergoing a PAC, pre-anesthetic checkup. She has been diabetic since last 15 years, but sugars are within limit. Which ASA does she belong to? Now, we know ASA is one when the patient is completely fit, no illness. Two is illness which is controlled. So, this is what will be the case here because her diabetes is under control. So the ASA classification, ASA1 is normal health, 2 is mild systemic disease which is under control, 3 is severe systemic disease, maybe not under control, 4 is severe systemic disease which is a constant threat to life, 5 is moribund, and 6 is declared brain dead. So these are the 6 categories of ASA staging which are there. Okay. I told you there was another question regarding damage control surgery, and this question was: a 30-year-old road traffic victim comes to the emergency and has hemoperitoneum and multi-organ trauma. Which of the following is an indication for damage control surgery? So this is directly from Bailey. This is the table which tells us which patients can go for damage control surgery and which patients can go for ETC, which is early total care. Now, damage control surgery, we know the lethal triad is hypothermia, acidosis, coagulopathy. But there are certain values which are there: hypothermia less than 34, acidosis less than 7.2, lactate more than 5, coagulopathy, blood pressure less than 70, transfusion approaching 15 units, and the ISS, injury severity score, more than 36. So here if we see blood pressure should be less than 70, this is wrong. Acidosis I told you should be less than 7.2, this is wrong. Hypothermia I told you should be less than 34, this is wrong. Okay. So here the correct answer is going to be coagulopathy, which would be the indication to carry out damage control surgery in this patient. Now there were a couple of questions from Shock. Which of the following are correct with respect to SIRS, systemic inflammatory response syndrome? So it is caused by release of lipopolysaccharide endotoxin from E. coli. This is true. So whenever these bacterial endotoxins are there, they can trigger SIRS. It is same as bacteremia? No. Bacteremia is not the same as sepsis. Right? Results in multi-organ dysfunction? Yes. White blood counts are more than 12,000. So these are the criteria for SIRS, and we know if 2 or more criteria are met, we call it SIRS. The 2 criteria can be temperature more than 38 or less than 36, heart rate more than 90, respiratory rate more than 20, or PCO2 less than 32. WBC more than 12,000 or less than 4,000 or more than 10% band forms which are there. This is a very important definition which has been asked many times in the exam. Now, sepsis is documented infection with 2 or more of SIRS criteria, right? So that was the old definition of sepsis, where you had to have 2 SIRS criterias and you need to have a documented source of infection. Of course, the term SIRS in sepsis 3.0 has been retracted. This is also a simple question. A surgeon is about to start a laparoscopic surgery. The floor nurse asks the surgeon to identify the patient, site and procedure. Which checklist are they following? This is the WHO surgical safety checklist. And you know, in the WHO surgical safety checklist, there are 3 components: sign in, time out and sign out. And each of the components you need to know about, because this has been asked in INI-CET and in the AIMS exam as well. So here they are following the WHO surgical safety checklist. Which of the following are correct to manage hypertrophic scars? Now, hypertrophic scars, silicone gel sheeting, and if you remember my lectures, I have told you that I also got a hypertrophic scar after my webbing got split after taking a catch. So I had to put silicone gel sheets at night because it was developing into a hypertrophic scar. Intralesional steroids, we know triamcinolone is the treatment for hypertrophic scars and for keloids, and laser treatment is also being used. I'll show you the flow chart in Bailey. So 1, 2 and 4 are correct. And this is the flow chart to manage hypertrophic scars. Immature hypertrophic scars, do pressure dressing, silicone gel sheeting. If it persists, then we do PDL or fractional laser therapy, right? So laser therapy is also being used in these patients. And we know that keloids versus hypertrophic scars, keloids have a racial predisposition. They are most common in the sternum, dark-skinned patients, and they don't subside with time and pressure. Hypertrophic scars can be seen in children, extensor surfaces, and they can reduce in size with time and pressure. So this is a keloid because it is growing outside the boundary. That is the main feature. It grows outside the boundary of the scar. More keloids. This is a tribe in Ethiopia where they deliberately induce these injuries to generate keloids so that they form a pattern. And you have hypertrophic scars which are limited in the scar area. Now the last question was the best measure of organ perfusion and the best monitor of adequacy of shock therapy, right? So here we know that if the option of MVOS, we know mixed venous oxygen saturation, was there, that would have been the best end point of resuscitation. This is the best end point of resuscitation. But here, because this is not mentioned, you will mark urine output, right? Urine output would tell me if organ perfusion and adequacy of shock therapy is working or not. CVP, central venous pressure, is used to determine the amount of fluid required, right? It is not telling me whether organ is being perfused or not. It tells me the amount of fluid which I need to give. That is with CVP and pulmonary capillary wedge pressure. Now we know that pulmonary capillary wedge pressure is a indicator of left side of the heart, whereas JVP is an indicator of right side of the heart. So more specific would be a pulmonary capillary wedge pressure. Another question from shock, this is the last one. Distributive shock, which of the following patterns would be there? Now we know distributive shock is a type of shock, warm shock, right? So first of all, it's a warm shock in which there is peripheral vasodilation. Now we know that when there is peripheral vasodilation in these patients, then what is going to happen? The cardiac output, right? So cardiac output in these patients will ultimately suffer, right? There will be vasodilation. Yes, there are warm extremities. There is reduced peripheral vascular resistance. That's because of vasodilation and warm extremities. Inadequate afterload is there, right? And there is low cardiac output, right? So this is inherent for most of the shocks, that the cardiac output is going to reduce. Most of them, I'm saying, not all of them. So that is the correct answer here. Low cardiac output is the correct answer in patients with distributive shock. And distributive shock can be which all types of shocks? You can have anaphylactic shock, you can have warm septic shock as well, right? So this ends our discussion regarding the UPSC CMS paper for 2024. If you have any further queries, you can write to me below in the comment section, and please do subscribe to my YouTube channel because I keep on posting important videos before all the exams. All the best.